The last case is a patient that came in. I entitled this post-transfusion cough. This is a 46-year-old man who had refractory acute myelogenous leukemia. He'd been treated with 2 different rounds of chemotherapy, and his hemoglobin was 7.8 and his platelet count was 14,000. He was short of breath and fatigue, and so the doctor decided to have him come into the outpatient center and be transfused with 2 units of red cells and 1 unit of platelet. He did fine during the transfusion at the hospital or in the Peds Center, and then he went home and an hour later developed this cough and increasing shortness of breath. So he came back into the hospital, and he was found to have bilateral RALs. His O2 saturation by pulse oximetry was only 30%. Even when he was on oxygen, his O2 saturation only got up to 80%. He was treated with steroids and Lasix and transferred to the ICU. A pulmonology consult was ordered, and the pulmonologist suspected that he had transfusion-related acute lung injury, or TRALI. And so they submitted this down to the blood bank, and we worked it up. We couldn't find that there was any evidence that he was having an acute hemolytic reaction, which is part of the differential diagnosis. His BNP was normal. It was only 49. And I always like to use this test because it helps me tell taco from trolley, and I'll get into that more in a second. We also ruled out that there was any contamination of that platelet unit with bacteria, and there wasn't. This was his chest x-ray, and you can just see that he had pulmonary edema throughout both lungs and in all lobes. And we reviewed the donor histories, and we found out that 2 of the donors were female, and I'll say why that's significant in a second. But we sent those 2 samples to the blood center to have testing for antibodies to neutrophils and to the HLA antigen system. 1 donor came back positive for HLA antibodies, and the second donor did not have any antibodies detected, so this told us that this donor probably was implicated as the cause of causing TRALI, and so that person then becomes permanently deferred. Well, what is TRALI? Well, it's whenever you get non-cardiogenic pulmonary edema either during or within 6 hours of a transfusion. That's the standardized definition now. The 6 hours is somewhat arbitrary, but they just put this in there so that everybody will be using the same definition as far as reporting these cases to the FDA. It's more common with blood components that contain a lot of plasma, so it's much more common with units of FFP and units of platelets than it is with red blood cells. There's about 250 mils of plasma in each bag of FFP, about 400 mils in a platelet, and only about 20 to 30 mils in a unit of red blood cells. It's also important when you're diagnosing TRALI that we have to make sure it's not related to any other cause of acute lung injury. And that's what makes it difficult when you're trying to really say it's TRALI or not TRALI, because a lot of these patients are very sick. And like in this case, a patient had had multiple rounds of chemotherapy, had pneumonia, and so that makes it harder to make the diagnosis. But this is, today, the most frequent cause of transfusion-related death. And as far as the clinical criteria, you have to show that there's hypoxemia. You have to show that there's bilateral infiltrates on the chest x-ray. You need to rule out circulatory overload. And then there's this whole list of signs and symptoms. Usually we see hypotension more commonly than hypertension. Commonly, if a person has a trach, you'll see froth coming out of the tube. But these are all really common symptoms. In the differential diagnosis, like I mentioned, we have to rule out transfusion-associated circulatory overload. I've also seen a severe anaphylactic reaction that looked just like a TRALI, and we can only prove it by showing that the person was IgA deficient that got the transfusion. We have to rule out the bacterial contamination, the acute hemolytic reactions, and then other events like a myocardial infarction or a pulmonary embolism that may occur at the same time the transfusion is occurring. just to spend a few minutes on TACO, this is simply when we transfuse too much blood too fast. Either the infusion rate's too high or the volume is too high. And usually it's in a patient that has underlying cardiac or pulmonary disease. And we get the same kinds of symptoms with dyspnea, orthopnea, cough. Usually you'll see a positive fluid balance. You'll see the pulmonary edema on chest x-ray. Sometimes it's just as severe as we see with trolley. Oftentimes the patient has evidence of heart failure, elevated central venous pressure. And I like to look in the lab to always get a BNP because in this case, the BNP will be elevated. In trolley, it's normal. This is just a recent case of TACO that we had, just showing that the pulmonary edema that occurred. In this case, it was more dependent than we saw with that case of trolley. But it's some of the things, clinically sometimes it's hard to tell, but these are some of the things I rely on when I'm trying to make the difference. Heart failure usually is not present in the case of the trolley, but it is in TACO. If you look at the fluid that's coming out of a trach tube, it'll be more of a protein-rich exudate, rich in fibrin, but in the TACO, it's just a watery transudate. Patients on trolley will not show much of a response at all to diuretics, but a patient with TACO will get significantly better as soon as Lasix is started. And as far as the white blood cell count, trolley, you'll see a drop in the patient's white blood cell count when the reaction occurs, and in TACO you don't see any change. And in the BNP, which is an indicator of heart failure, it's normal in trolley, but it's elevated in TACO. When a trolley case is suspected, we get a blood bank transfusion reaction report from the nursing unit. We will complete what we call our Tier 1 testing, which allows us to rule out that it wasn't due to hemolysis. Then a pathologist gets consulted and we will try to investigate it. If we think it truly is trolley, then we notify the blood center immediately. They will review the donor history because we don't know anything about the donors, that's all anonymous. So they will review it to see if it's female or male. And what we found out with trolley is it's much more likely to be caused by a female donor who has had several children. Then it's second most common is a woman who's not had children, and third most common is a male donor. As I showed earlier, we do testing for antibodies to granulocytes, and if they're positive, then that donor gets permanently deferred from ever donating plasma-containing components again. This is a slide of a lung of a patient with trolley who died, and this shows you all the edematous protein-rich fluid that's out in the alveoli of the lung. But the important thing is where these arrows are. These are the capillaries of the lung, and you can see that there's just these clumps of granulocytes in the lung. And what happens is we're transfusing a unit of blood that has granulocyte antibody in it. That antibody then binds to the patient's white blood cells, causes them to agglutinate. They get trapped in these small capillaries of the lung and set up a severe inflammatory reaction that then injures the capillary walls and allows all this fluid then to leak out into the alveoli of the lung. And that's why we get this white out picture on the x-ray. And so that's why we've now taken these measures nationwide to prevent trolley by trying to exclude donors who have granulocyte antibodies. And as I mentioned, it's more common in female donors. It's been found that about 20% of all women have antibodies to their white blood cells. And so plasma, like I said, has the most volume and it has the most antibody in it. So for the last 2 years now, we've only given plasma that come from male donors. And platelets, there's a national shortage of platelets. We have a very hard time getting enough platelets, so you can't just exclude half of your platelet donors non-discriminately. So what we're trying to do in those cases is about 40% of the platelet donors are women, and so now they ask them with the history if they've had pregnancies. If they've had 2 or more pregnancies, and they know that they're at higher risk of having been exposed to foreign white cell antigens during the pregnancy from the baby, and they're more likely to have white cell antibodies. And so in that case, then they actually do a test for white cell antibodies. If it's positive, then they will defer them from donating platelets, but they do allow them to donate red blood cells. And so what's been the effect of this? Well, this was some recent data. This was just reported this month from the American Red Cross. They looked at about 3 million donors. And what they found is that since they put these changes in place, that now 95% of all the plasma has come from males. And at the same time then, the number of fatal TRALI cases that have been reported in the United States has dropped from an average of about 6 per year down to none in 2008. Community Blood Center started collecting male-only plasma in March of 2007. Before then, they had about 5 cases of TRALI, not fatal cases, but just total cases of TRALI reported throughout the Kansas City area. And they've only had 1 case reported in 2008. So clearly this strategy, I had my doubts that this was the real cause of TRALI when it was first discussed, but clearly it's had a positive effect in reducing the incidence of TRALI, and it really is probably not going to be much of an issue in the future. So what can we do to ensure that we don't have transfusion reactions at St. Luke's? Well, we need to, luckily we have a very good blood center in this city, and they carefully screen all potential donors to rule out those that may have a high-risk lifestyle that could have infectious disease involved with it. They do very accurate identification of blood groups and infectious disease testing at the blood center. They accurately label the blood components. It gets stored and transported in the proper conditions to the hospital. We need to make sure that physicians are ordering blood appropriately only when it's absolutely needed. We need to make sure that the pre-transfusion sample is drawn on the correct patient and that it's accurately labeled. Then we have to make sure the blood bank gets 2 ABO types before we issue blood. We have to make sure that all of our compatibility testing is accurately performed. We have to visually inspect the blood components to make sure there's not bacterial contamination. We want to promptly deliver the blood up to the floor so that it doesn't sit around at room temperature and increase the likelihood of bacterial growth. We want to make sure that 2 people always positively identify a unit of blood and the patient at the bedside so that we can prevent mistransfusions. We need to make sure that when we start that unit of blood that it's done aseptically so that we don't contaminate it with bacteria, that we transfuse at a correct flow rate to prevent TACO, and that we monitor our vital signs at frequent intervals. And that's the last slide.